Good morning. How's everybody doing this morning? Welcome to Psyfeld. For the clerks, you may have to remind me, I think I have this right, just to double check though. Is next Friday your shelf exam? It is. Okay, so that means that this morning's Seinfeld session will be the last of the calendar year. So this is it. And we will see everybody back in January. So let's make this discussion. Let's make it a good one. So the focus this morning is going to be on the Kiss Hello. So I'll first pitch it to the third year clerks. Any behaviors, any characters from this episode you'd like to discuss?
Concept that my friends and I had talked about for years is one of those things that we couldn't really understand how it's existed in society for so long. And especially it's funny now because of a pandemic, it's really unthinkable. Um, but I kind of positioned myself in Jerry's shoes, and I thought to myself, what would I, if I was, there's something that everyone accepts as normal, but I truly don't think is normal. Would I subject myself to that, several times a day for the sake of making everyone else happy? And that was an interesting thought process. And the show kind of takes it to a comedic extreme by kind of having Jerry completely ostracized as a result of his decision. And I think, I think I'm probably someone who would kind of just go along with the flow. But there's definitely something interesting to think about, given how the show portrayed the kids a little.
Yeah. So there's a couple of teaching points, either of which really may appear on your exam a week from now, all right, that you've kind of touched on here. We should probably elaborate on. But before that, I just want to make a comment. And, Larry David doesn't need me to sing his praises, but with 2020 and where we are today, boy, was Larry David ahead of his time, right? And I find myself saying this with regard to these the societal, social, and psychosocial issues that he actually, deep dives one by one. They seem to come up again and again as recurrences, and because of that, again, it's only my perspective, but this situational comedy is absolutely timeless. So here we go again. One thing that I think students have to focus on here is what is called a culturally sanctioned behavior. So this is behavior that is considered to be within the norm and therefore acceptable by a given culture or subculture. All right, and there's many examples of this, some of which we'll discuss right now, but any of which can appear on your shelf exam or any final exam. What you have to appreciate in terms of sitting for an exam is that I would think that about 60 to 70% of the time, the question writer is trying to look for your discovery that this is considered to be sanctioned or normal within the context of a given culture, and therefore perhaps choice A, normal behavior or no intervention necessary, is the single best answer. They want you to identify that. However, what is also on the table might be the actual name of the culturally sanctioned behavior itself. So I think 60-40, you're probably going to be asked normal, but a little bit lower percentage of the time, you may have to identify the name of the actual culturally sanctioned behavior. And one example of that would be hoodoo, right, with an H. Hoodoo or root work is culturally sanctioned behavior focused in the Southeast United States and in particular the Bayou region of Louisiana, where individuals indigenous to that area believe in spells and brickwork, brick dust, as warding off evil spirits. If one were to put down brick dust around their house to keep themselves safe, really nobody visiting that area, nobody understanding of that subculture or that culture's sanctioned behavior would question it. Now, on the test, such an individual might land at Newark Liberty, begin to put down brick dust in Terminal A, and then have TSA transport the patient to one of my medical students taking call at acute psychiatric services in Piscataway. I'm not really sure why they took the patient down the turnpike to you on call, but that's what they did. The observation would be that your provisional diagnosis might be of paranoia, therefore rule out a primary psychotic disorder. But after taking a patient history, after talking to the person and recognizing not only are they indigenous to the Bayou area of Louisiana, and in that area, this is sanctioned behavior, you will discharge the patient from that psychiatric evaluation with no further follow-up. Right. So that's the general idea of culturally sanctioned behavior. And I think kissing people upon seeing them hello in the United States prior to March 2020 is or was culturally sanctioned behavior. Right. So that's one major teaching point that I think students must keep in mind, prompted by this episode, the kiss hello. The other thing that medical students have to look out for is a related phenomenon called culturally bound syndromes. Because culturally bound syndromes have a commonality with culturally sanctioned behavior in that you're looking at behavior indigenous to usually a geographical area. The difference, though, that separates one from the other is that the culturally bound syndrome within that geographical locale is considered to be abnormal. And that means about 100% of the time, students must identify in their clinical vignette what the behavior is and what the psychiatric label, the actual diagnosis is for that behavior. And there are multiple examples of that as well. Atake is one that's quite common. DHAT is another one. Ghost sickness, amok. I mean, there are several names. I would refer you to your favorite board review text, as well as the glossary of the DSM to briefly review all of those types of syndromes. We could certainly discuss this in more detail during rounds today. Okay, but that's a culturally bound syndrome. All right. So from that perspective and kind of the opening dialogue here, any questions pertaining to these two phenomena? One considered both are geographically isolated. One considered to be normal within that geographical locale. The other one is considered to be abnormal. Thoughts, questions? Any other observations? If you want to stick to the character, any observations with regard to Jerry here? Okay, so what other characters you want to discuss this morning?
Actually, I have something to say about Jerry. It's almost as if he had a phobia when it came to people kissing him on the cheek. I'm like, this reaction that he's having to it, built up so much anxiety because he never said anything to anyone. It's literally something that ended up ostracizing him because he just had an inappropriate reaction by the time he finally said something. I just thought, this is a very strange guy. Just say something. He let Lane's friend do it for so long that he's okay. At a certain point, this has to stop. Okay, Jerry, when is it going to stop then? And the people, you have to leave the building because we can't kiss you on the cheek. Like, that is so weird. But I think he would have said something earlier. It really ended up being a huge source of anxiety for him.
So if we look at Jerry and if we think that he's anxious, especially if he presents the clinical attention with a chief complaint of mounting or debilitating anxiety, phobia, and I think the single best answer on an exam would be specific phobia, may be your single best answer. A phobia, specific phobia, is defined as an irrational fear of an object or a situation. And previous to the, I think the last two revisions of the DSM, that's the 4 text revision as well as DSM-5, there were specific names for each specific phobia. So medical students had to memorize the different clinical names depending on what the phobic object is. Not too long ago, the DSM, the American Psychiatric Association, simplified this and created 4 categories that we will try to neatly fit and categorize our patients into, depending on what the phobic object is, depending on what their fear is. Anybody know the 4 general categories of specific phobia? One is animal type, right? Which clearly is not what's going on here. If we are ruling, hypothetically, if we are ruling Jerry in for specific phobia, it would not appear to be animal type. The second type is situational type. All right, so that's tricky here. If we look at Jerry being irrationally fearful of situations in which people were welcoming him, that might be towards the top of our differential. Okay, so that's something to consider. Blood injection injury type, so vasovagal response. Clearly not what's going on here. And the fourth and final category or subcategory of a specific phobia is environmental type, right? So storms, lightning, etc. Not what's going on here. So if Jerry does rule in, and if we find through perhaps not only a psychiatric evaluation, but perhaps even psychotherapy, that Jerry's anxiety is caused by an irrational fear, and we feel that that fear is the particular situation of being welcomed because of the imminent kiss hello, then maybe specific phobia, situational type. Now, as you probably would guess, individuals don't always neatly fit into one of these artificial categories or any artificial categories in the DSM. And they may actually have a phobia, but it may not be to an animal situation, blood injection injury, or an environmental stimulus. So there is a fifth and final category, a grab bag category, which is specific phobia, other. And while that is a somewhat common diagnosis in clinical practice, it is one that you are very unlikely to see on your exam. Usually, shelf exams do not have not otherwise specified type of answers to their clinical vignettes, but it does exist. Specific phobia, comma, other, to serve as a catch-all for those that are not fearful towards or of animal situations, blood injection injury, or environmental stimuli. Right. So that's specific phobia. Anything else observed, Jerry or any other character in the Kiss Hello?
Jerry's grandmother. Well, one thing to comment on in regard to the B plot this episode with Jerry's uncle and his grandmother. I'm not sure if this is exactly what was going on, but considering the fact that his uncle really puts his mother in a home for reasons not for the benefit of the patient, but rather to save money, I wonder if that could be considered a form of elder abuse. And I know that's something we look for in the psychiatric history, any kinds of forms of abuse. So it was just interesting. And of course, it's played comedically, but just given the fact that it was more so for the uncle's benefit than, in this case, I guess the patient would be Jerry's grandmother, if that's something to look out for or touch on.
Yeah, and again, I think the clinical pearl here is that if there is any suspicion of elder abuse, a referral needs to be made, right? So it's really not the physician's role to pursue or investigate. There are outside entities that provide that resource that will do the investigation. So any suspicion, in this case of elder abuse, requires a referral. I think that's a major teaching point here, that physicians are in that de facto role to discover elder abuse and make sure they tap into the resources available to provide that investigation upon suspicion. So that's a good point. Mm-hmm. And then with regard to Nana's behavior, are there any things concerning to you with regard to what you observed?
Definitely in regard
regards to her memory seems to be escaping her. She is not oriented to time. She thinks it's back in, I don't know how many years ago. She essentially thinks Jerry's uncle and his mother, they're both children. They just got $1,000, or they just got $100 from their father, but this happened like 50 years ago at a horse track. So definitely some early, maybe even later signs of dementia manifesting here, which could warrant the placement in a home to help with that. But again, the reasons why aren't exactly to the benefit of her.
Right. So this brings up a discussion about what is now referred to as major neurocognitive disorder, previously known as dementia. Certainly, if you've never watched Seinfeld before, the situational comedy, and this is the first time you're meeting Nana, the clinician is going to make sure that the memory deficits or the cognitive deficits in general aren't due to a more acute process and therefore don't warrant the primary diagnosis of delirium. All right, delirium is potentially life-threatening, and it's something that clinicians cannot miss. So, when in doubt, work up a delirium. In such cases, not only would there be a diagnostic interview, but also looking for the potential underlying cause. And we discussed this on rounds, that those underlying causes usually are part of a didactic where we have students watch Shakespeare's Macbeth to be introduced to the character of Lady Macbeth, who is not only delirious, but whose name allows for an acronym to remember those potential etiologies, right? So I Heart Lady Macbeth is the acronym that we've used and we reviewed last week with regard to the potential etiologies of the acute aspect of mental status change, that is delirium. Delirium is unlike any other mental disorder in the entire DSM, and conceptually may even be removed from the DSM because of that. For every mental disorder, the clinician must rule out that the behavior isn't due to the direct physiologic effect of a substance or another medical condition. Delirium is the direct opposite. It's a behavioral disturbance or manifestation of an underlying substance or a medical condition. So it's the exact opposite of every other mental disorder. It's only the behavioral manifestation of something that's going on, either latent or occult, with regard to medical conditions and or the direct and physiologic effects of a substance. And what those medical conditions could be may be, again, remembered by the acronym I Heart Lady Macbeth. And again, for those that may not have been part of that discussion or didactic last week, we can review this again on rounds this morning. Once we rule that out for Nana, there's kind of a little bit of a middle ground. That is, in ruling it out, what the clinician is also doing is helping rule in the condition known as major neurocognitive disorder, some etiologies of which, if corrected, may reverse the cognitive deficits. And we often hear this term reversible dementia. And that's exactly what that gets at. It's kind of a middle ground between delirium and major neurocognitive disorder. Once the potential etiologies are investigated and ruled out, then we're likely struggling with one of the two major causes of major neurocognitive disorder, that being vascular disease or the condition known as Alzheimer's disease, or major neurocognitive disorder of the Alzheimer's type, right? So that's kind of the progression with regard to how someone would pursue the workup of Nana's cognitive deficits. Throughout all this, especially after delirium has been ruled out, the clinician must also consider in the differential major depressive disorder, because MDD in the elderly may present looking exactly like major neurocognitive disorder. That is, major depression in someone who is elderly presents with cognitive deficits, not likely depressed mood, anhedonia, and other related neurovegetative signs of depression as outlined in the DSM, that is SIGI-CAPS. So many clinicians, geriatricians, will often have a low threshold after providing a geriatric depression scale of starting a low-dose antidepressant to make sure that they are not missing an occult depression presenting as cognitive deficits. The only other thing I want to make sure we discuss this morning is this other condition formerly known as mild cognitive impairment, or MCI. 2013, the DSM-5 changed that definition to mild neurocognitive disorder. So we have major neurocognitive disorder and mild neurocognitive disorder. And this is something that you must be prepared for on exams, because in this situation, we have one of only 2 instances in the entire DSM where we've now identified a condition that is defined by not being clinically significant. That is, the way mild neurocognitive disorder, or MCD, differentiates from major neurocognitive disorder is that the individual's functioning remains intact. If it doesn't remain intact, if there's clinical significance, that's major neurocognitive disorder, the illness formerly known as dementia. Right? The only other illness in the DSM that is defined and differentiated from another mental illness by the fact that it is not clinically significant is hypomania. Right? Hypomania looks exactly like mania. The same exact signs and symptoms. If you look at what a manic episode's definition is, and many of us have learned that through the acronym DIG FAST. Well, DIG FAST also defines hypomania. One major difference separating the two is that hypomania is not clinically significant. Okay. The other is that it doesn't continue for 7 days. Right? 7 days is the cutoff with regard to the quantitative difference between mania, 7 days or more, and hypomania, less than 7 days, but at least 4 days. Right? But those are the only 2 conditions of the DSM where qualitatively you have one condition, mania, major neurocognitive disorder, that is defined through clinical significance, and syndromes that look very similar, hypomania and mild neurocognitive disorder, defined through the lack of clinical significance. Right? So that's nano. All right. Any other thoughts with regard to other characters in this episode? Anything from Elaine or George or anybody else?
George, I've got something from George.
What's going on with George?
So, George just sort of kept belaboring this point about the delicate genius, and this upset him so much that I'm like, there's got to be something there. There has to be something there. It's like, what does he have against medical professionals? Who traumatized him in the past and caused him to act out in these situations where a normal person would not get this upset? I feel as though.
Any Seinfeld fans in the crowd? Because I think we might have a working diagnosis here, right? Maybe not necessarily a diagnostic label, but especially if George were in psychotherapy, we might have something here to work with, to the extent that his interaction here with the physician, with the physical therapist, is clinically significant. I mean, he's coming for help because of A, B, or C. And the clinician identifies that a source of his clinical significance happens to be this interaction that we've all observed now when watching this episode. And somehow George was referred and was engaged in psychotherapy. The hint here, and I'll open this up too to the undergraduates who are with us this morning. Any thoughts with regard to, having watched prior episodes, what might be critical in understanding what's going on here? I mean, the question is, why does George have this problem with the medical field? And again, this could be something where, and we would of course ask the individual, any past trauma, generally speaking, or what's been your interactions with physicians or physician extenders? And it doesn't have to necessarily be a trauma per se, but it could just be adverse interactions where the medical field simply has not gained this individual's trust. And when your health is on the line, when there's something going on in which you need help, and it may or may not be life-threatening, it's hard to give up control and put your health in someone else's hands when you don't really trust that individual, the oath they took, or the system within which they practice. So we might get, I did bring up psychotherapy before, to this idea of trust and how that's established. And it's established very early. Whether you listen to Freud oral phase, or whether you listen to Eric Erickson more from a social psychology perspective, basic trust versus mistrust. I'm thinking that George's problem may not be with this physician in particular, but might be something that happened a long time ago during his childhood. And again, I'm not necessarily thinking of trauma. I'm just thinking of perhaps, for lack of a better phrase, stunted development. In this case, per Erickson, psychosocial development, or if we're going to look at it from a Freudian perspective, if there are any Freudians in the audience, a psychosexual perspective or breach in development. So the general idea here is that it isn't the physician that George is having a problem with. It's actually authority figures. And an individual's appreciation for or disdain of authority figures has everything to do with their primary relationships formed with their parents, right? So once the superego begins to develop, we have our parents central in that role because they are the ones funneling in society's prohibitions with regard to the 2-year-old, 3-year-old's behavior. And then soon thereafter, there are parental extenders, teachers, police, etc., and eventually physicians, right? So very similar, and there's a nice parallel here with regard to Jerry's potential specific phobia, in that it's not the phobic object per se, that is, what the phobic object represents from a Freudian perspective is much more important than the actual fear of, let's say, somebody welcoming you with a kiss. There's something really behind that. The phobic object just represents that inner fear, that inner irrational fear. Well, so too, George's behavior towards the physician looks at the physician playing a role. That is, the physician just represents, it's an object that represents something that is subconscious here. And that subconscious problem or conflict that George has is likely emanates from the primary relationship and the trust that perhaps didn't develop with regard to his relationship with his parents. So any closing thoughts? We have about 2 minutes left here. Any final thoughts with regard to the kiss hello? All right, so go, please, one more. Mm-hmm.
Yeah, I don't know if this is maybe clinically significant, but the physical therapist in the episode did display like a couple of behaviors that seemed almost just not necessarily again clinically significant, but just a little bit abnormal, almost like when she decided not to drop Elaine off right at her apartment and made her walk 3 blocks with all the ski equipment. When she, decided that her hairstyle was in fashion when in fact it was apparently at that time very outdated. She just seemed like a little bit behind the times, which and just like a little bit, there's like I guess there's a phrase like some people just get it. She kind of does fits the opposite of that. Even though putting in the extra work to drive all the way around New York City would have gotten Elaine home, dropped off at her apartment. She decided not to do that. So yeah, that was just something that I observed.
Yeah, and in saying that she doesn't get it, maybe the idea of social awareness and social cues. So along that line, I think the one word I do want to introduce here is egocentrism, right? Which is an individual being self-absorbed and simply having the incapacity to view a situation through anyone else's eyes or viewpoint than their own. She just lost the perception. She lost the viewpoint that where she was in driving and what Elaine had to carry should have suggested to her that pulling closer, even though it may have been more inconvenient to the driver, was the right thing to do. Again, we're getting at, social norms, right? So this does relate to the idea of what is culturally sanctioned behavior with regard to dropping someone off, and are you incapacitated to see from another's perspective their anticipation that you would have done this different? Okay, so that's egocentrism. Right? Now, I don't know. Egocentrism is a risk factor for developing mental illness. I'm not sure if there's a mental illness here to define or even diagnose, but certainly the idea of egocentrism demonstrated in the physical therapist, that's definitely there. Again, the lack of social awareness owing to her incapacity to perceive a situation through anyone else's eyes but her own. All right, so a closing thought. The Kiss Hello, the episode, the title, alludes to arguably one of the best movies ever made called It's a Wonderful Life. All right, so I did tweet as a suggested or an additional viewing this classic Christmas film, It's a Wonderful Life, which itself has significant psychiatric undertones, all of which we'll have an opportunity to discuss in more detail for those who watch the film during rounds today. So we'll leave off like that. A quick segue in terms of another movie, and get prepared for our 12:30 Periscope session. That's Night's Watch, where we will be discussing the Disney film Lady and the Tramp. So we'll see everybody back on Periscope at 12:30. Thank you.